Hi, am I audible, Srujana?
Yes, sir.
Yeah, so what do I do now? Sorry for the delay. I was just arranging some stuff, so it took me some time.
Sir, please share your screen and start the session,
Is
sir.
the background fine?
Everything is fine, sir.
Hi, am I audible? Okay, so I'll go for the, I should also go into YouTube now. Ma? Okay, is my screen seen? Not this. Okay. Not this. Hi, good afternoon, guys. This is a new system for me. I'm trying a little. Am I audible? Hi, good afternoon, guys. This is a new system for me. I'm trying a little. Am I audible? Yeah, fine. So I have set the thing for questions. Chats. Okay, that. Okay, so let me straightly jump into, there's some lag between this, so let me just reduce the volume. Yeah. Okay, fine. Guys, I'll be looking parallelly at if there is any questions when we are discussing what the probable recall question is. So I'm straight away jumping into the question format, whatever, there are around 25 gastro questions which we have got from our students. So let me dive into the first question. What they have asked is, patient presented with recurrent upper abdomen pain. Just a second. Okay, one second, just see. Let me. Fine. Yeah. So sorry for the delay. So the first question is, patient presented with recurrent upper GI bleed and also had early encephalopathy. What is the staging of cirrhosis? Option A, stage 1, stage 2, stage 3, stage 4. First of all, is this the question that is asked? Second, the answer I would choose is stage 4, only because patient with an upper GI bleed who has recurrent symptoms and has encephalopathy probably secondary to the UGI bleed, it being a precipitant, means that first is the question compensated or decompensated. Now we know it's a decompensated CLD. So when patient has encephalopathy, one, if it is natural history of liver disease, that means it's a late stage. Second, a patient after upper GI bleed gets into hepatic encephalopathy also means it's a late stage. However, one of the things that they haven't mentioned is whether ascites was there or no. That is something which was not there. So considering that if somebody goes towards recurrent bleed and has encephalopathy, probably it is a later stage of the disease. I would say that you should probably go for first step is decompensated, which can be 3 and 4, and they have told whether it's actively bleeding or not bleeding is a question. So I would have probably gone for stage 4. You guys can be open for discussion right now. Let me see the chat box if there's anything. In case if there's any doubt, just get back to me. We will, based on the chat box things, let me discuss back to this question later. Now, the second question is a patient with alcoholic hepatitis with bilirubin 4.6. Mind you, bilirubin 4.6, INR, students were not sure. Ascites was mentioned for the previous question. So if ascites has been mentioned in the previous question, then the question is whether they had asked, whether they had told active bleed or not. Now, assuming the patient has gone towards hepatic encaph because of the bleed, it means to say that patient actually has bleeding. Okay, bleeding can precipitate hepatic encephalopathy. I would have gone for stage 4. Okay, guys, thank you. So I think the first question is clear. Let's go to the second question. Bilirubin is 4.6. INR is probably 2.5. Let's be sure based on what it is. They've asked you to calculate the MADRS discriminant factor and then decide the management. Now, let me tell you frankly, if this was the question, or there may be slightly a different form, INR 2 is obviously a significant one. Bilirubin 4.6 also is a significant one. Now here, let's go into the guidelines, what they say. Based on ASLD or EASL, which are the two famous standard guidelines, they say that corticosteroids is indicated in severe alcoholic hepatitis. Okay. They do not say it has to be just based on DF. Okay. So there are various definitions based on various trials, but what is commonly done is DF. If you say patient has INR of 2 and predict what the probable PT is and then make the difference and then do it, definitely the patient's again DF score will be quite high. So this patient has severe alcoholic hepatitis. And in the question, some students are also telling that they had mentioned that patient had ascites also. Now, a patient with alcoholic hepatitis, if has bilirubin 4.6, INR 2.2 with ascites, it falls under the definition of severe alcoholic hepatitis. Severe alcoholic hepatitis is again an indication for steroids. Of course, you should look into whether there are any contraindication, but in the question there are no mention of contraindication. So in this question, I think you guys can go through these answers. There are different forms of STOPA trial is something important to know. Second, MELD score again is quite important. Glasgow alcoholic hepatitis severity score again. There are various scores to tell you whether the patient has severe alcoholic hepatitis. Based on all of them, in Asian population, you have a new one called the magic scoring. So based on all this, you can tell whether the patient is actually having severe alcoholic hepatitis. So the probable thing what the questioners are trying to test is severe alcoholic hepatitis, what do you want to do? So the only thing which has helped to reduce the mortality to some extent is steroids, not anything else. Okay, but there are various other things. But studies say that MELD score and Lilly combination model are one of the best ones to predict this particular outcome. Okay. So coming to, let's see if there are any talks on this question. Okay, few of the students have mentioned abdominal pain is present for the patient in question 2. Even if there is abdomen pain, it is not going to change your answer, because the question here is what is the management for the patient. If there is ascites and there you are going to manage based on DF score, the decision based on DF score is either to give steroids or not. Okay. If they have mentioned ascites is there, pain abdomen is there, what is your management? Then I would have gone for IV antibiotic. Probably we are dealing with SBP also. But in the question, there is no indication of SBP at all. They're clearly told calculate TF and strategize your management. So if this question is wrong, please type in the exact question. We might have further better discussion. Okay. Pentoxifylline anyway is out of date as of now. No treatment cannot happen there for severe AH. You give prednisolone until and unless there are no contraindications. Okay. Okay. Next question is, there is history of recurrent acute pancreatitis. ERCP image was given. Some of them have told there are multiple intraluminal of CBD filling defects. So that means that it is an intraluminal problem. So definitely pneumobilia is out. Portal biliopathy will have extrinsic impression. I will show you the different forms. The answer is mostly ascaris and choledocholithiasis. Now, based on how it looked, you guys have to decide. If it looked like intraluminal filling defects multiple, like this, like what's behind the scope now, what is this? This is choledocholithiasis. But if it looks something like this, a long one like this with a linear thing, then it probably is ascaris. Okay. So most likely from the discussion, I would say that it's probably choledocholithiasis. Now, these are different forms of how portal biliopathy will look. But overall, what you should know is in portal biliopathy, the CBD will look constricted from outside because of the varices that is present. And some of the places there may be ectasia. Okay, that's the ultimate thing that you should know in portal biliopathy. But usually the question may not go to that level of expertise. Most likely what we are dealing with in this particular question is choledocholithiasis, which has led to recurrent biliary pancreatitis. Okay, Dr. Parth, if you feel it's ascariasis, it's basically based on what you saw. Okay, if you're seeing multiple small filling defects like this, it is choledocholithiasis. If you saw a continuous one, something like that, let me just erase it. Something like this, then it's ascariasis. Again, a question which is totally based on your intuition on what exactly you could see. Next question is, AIH simplified scoring system has all of the following except, okay? The answer to this question is bilirubin. Now this again, I hope was discussed in the QRP session. What you should know, there are two scoring systems. One is the complicated one, that is the international based system, which was used before, and the recently simplified one. Now the simplified one, it's called the simplified one because one, it does not have these many parameters which were there in the previous one. That means historically there is no gender, drug history, alcohol history, or other immunological diseases. With respect to investigation, there is no alkaline phosphatase or AST or AMA or HLA, and treatment response has been removed. Okay, so what is included is only these many factors, that is autoantibodies, immunoglobulin levels, histology. Though it is simplified, most important thing is people will get confused telling that histology is not there. No, histology, liver biopsy is still a part of the answer, and viral markers being negative. So there are only 4 points in simplified definition. So the answer is clear cut, it's bilirubin. But if you feel that they have asked something different, please put up in the chat box. Okay. Now, the next question is, patient is on rituximab for various reasons and also has HBV. You have to treat the patient, but how long will you treat the patient after stopping rituximab? If that is the question, the answer should be 6 to 12 months. This is totally based on this particular chart, which says that if a patient is on B cell depleting agent, that is rituximab, then it's one of the most powerful immunosuppressant, especially with respect to immunity against the hepatitis B. So you have to give treatment for up to 12 months. If the option had only 12 months, then 12 months is the best. If it had 6 to 12 months, then 6 to 12 months will be the best answer for this particular question. Okay. Okay, next one. What is the diet that is advised in exocrine pancreatic insufficiency? See, exocrine pancreatic insufficiency, to be frank, you don't advise much. You make sure that the patient requires pancreatic enzymes, and if that it's not working, you see whether the patient is compliant. If not, then if the patient is compliant, then you add on pantoprazole or any PPI with this particular one. Then you base upon the dose. If the patient is still not responsive, then you suggest to have an oil-based diet, which is predominantly medium chain triglyceride, because the advantage is it won't require any lipolysis and hence lipase for absorption. Okay, so the best answer for this question is medium chain triglycerides. And this is a line that I picked from Schlesinger, 942 page number, which says that medium chain triglycerides is the answer for probable answer for this question among the options that is given. Okay. Next question is liver enzyme question. That's much only I know. Now, from the options that we read, we all know that ALT is more specific than AST. So probably go for A because that is the best answer. And rest of them, it's all half and half that I got. But if you go through Schlesinger 1156, the answer to most of these questions is there. First is what you have to know. Like I've already explained in previous classes, remember A, S, T. S is for C. That means it's everywhere. So it is there in the cytosol and it is there in the mitochondria, both. Okay, so sometimes they'll ask where it is present. So AST is present literally everywhere, that you have to know. But it is also present in multiple other organs also. Okay, but ALT is present only inside mitochondria and it's usually present only in liver. So it is more specific that ALT is more specific towards liver. First point. Second is, the question is, if they are raised, it means that probably there is a cell membrane leakage or because of some reason they are coming out into the serum. But it doesn't mean there is necrosis. Now, necrosis is not required to release AST. So that means if there is raised AST or ALT, it doesn't mean that there is necrosis. Just because it is high, it doesn't mean anything with the severity. So if they tell you that AST, ALT raised means there is necrosis, no, there is no necrosis. Okay, so that is probably answering the other question. Third is somewhere I found out reticuloendothelial system. All that you have to know is even Schlesinger, they mentioned that it is probably cleared by cells of RES. Okay, so that is something probably, again, it will help you answer one of the options. Yeah, that should be sufficient for that. Next is, okay, one of you guys have told MCT and oligopeptides were given in the question, in the previous question. Oligopeptides, again, you prefer oligopeptides because there are proteases in pancreatic enzyme supplementation. It makes sense to give oligopeptides with MCT diet. Okay, so at least it's better than the other options from the options that is given. Yes, okay, good. So next is accelerated hepatitis B immunization schedule. What is the right answer? Now, I'm not sure in the question if they mentioned whether they had mentioned any specific vaccine. Is it for Engerix B or Twinrix or Hepatitis B? Okay, so I would have gone. See, why is it called accelerated? You give it at regular frequency, at least the initial few dosages. So according to the recent what this picture I got, it is for Twinrix. For Twinrix, it is 0, first week, first month, and then 1 year. So this is the best answer if it is Twinrix. If they mention Engerix B, then the answer will be 0, 1, 2, and 1 year. Okay, so there is a that is something you have to be clear about that. Second, even CDC guidelines have gone through what they say for Twinrix. It is 0, 1, 6 months is standard. The new one that is 0 days, 7 days, 21 to 30 days, and 12 months is considered as accelerated. Okay, so I hope they had mentioned about what vaccine it is. If not, then this table will help you what the probable answer is. Okay, so in this option, if they had, this is what I wouldn't have answered because 6 months is never available. Most of the time you have now 1 year, and the initial dosages, everything gets, it happens in more frequency. So based on the vaccination they have mentioned, the dosing changes. The best answer would have been 0, 1 week, 1 month, 1 year. That will be the accelerated one, especially if they ask you what exactly it is for. It is for Twinrix, which has both hepatitis A and hepatitis B vaccination. Okay. Next is Now, cirrhosis with HCC, 3 nodules, each less than 3 centimeter, then the patient should be considered for liver transplant. That is what they have tested, and they have told up in one of the best studies done ever, NEJM 1996 itself. It's called the Milan's criteria. So if single tumor less than 5 or up to 3, each less than 3, you consider for liver transplant. Now, some of your students may ask, sir, they still didn't mention about CTP A, B, C, and how would we know? I would say that now, if it is CTP A and all of them are close together in a single lobe, then you may consider, resection. Okay, but when they have not mentioned specifically, then what they are probably trying to test is about idea of Milan's criteria and what you are going to do about that. Okay. So in the previous question, if they have not given the name of the vaccination, then let's assume that based on the options, at least tell me what the options were so we can rule it out. All that you have to know is it is 0, 7 days, 1 month, and 1 year. Okay. If it is Twinrix, if it is NGRX B, which is available in India, then it becomes 0, 1 month, 2 months, and 1 year. Okay. So that would be the best answer for the question. The next is a pediatric child. I'm not sure about the age. Probably few of you have told the age was 2 years. Some of you have told 3 years. Had severe liver injury. Which of the drug is implicated? INS, valproate, nitrofurantoin, and gatifloxacin. I would probably go for valproate because, see, this is a list what happens when common pediatric drug-induced liver injury. What they are probably trying to test is, yeah, acetaminophen is out because that's not there in the option. Amoxiclavulinic acid doesn't have the special pattern of especially occurring in kids. But when it comes to valproate, what they have mentioned, you specifically see less than 2 years, they are most vulnerable. Okay. And if it is 3 to 10 years, 1 in 6,000 or 1 in 12,000 can get this particular problem. Okay. And minocycline. So from all this, what I could make out is valproate would be the best answer in this pediatric based question. Now, in a similar way, a question was asked for adult who was treated for pneumonia and developed severe hepatitis. They said that bilirubin was like 10 and 9 and alk-phos was 340, which also with AST and ALT elevated, but less than that of ALP. So it is mostly a cholestatic pattern from the question. So cholestatic hepatitis. So the best answer is amoxiclav. Again, for this, there are a lot of drugs, like I've explained in QRP. If you remember few of things, I remember putting cholestatic hepatitis, amoxiclav, one of the cause. You guys might have got this question right. You can see that cholestasis hepatitis, amoxiclavulinic acid is one of the one which is important and is being mentioned clearly in the books. Okay. Next is clinical scenario based question in a patient with known HCV. Rituximab was asked, and what's the probable drug is what is the probable condition? I'm really not sure if they showed you a photo of the patient or they just told you that rituximab was given for a skin condition. What's the condition that you're dealing with? And most likely it is cryoglobulinemia. I would be happy if you guys are able to give me more details on this question so that it is easier for us to come up with an answer. The next question is an asymptomatic HCV patient, RNA is 249. What is the management? Mind you, unlike HBV, okay, where you see for values, here there is no use of values. As far as it is positive, patient will require directly acting antivirals for treating the patient. Okay, simple, fairly simple question. Lilly model is used for, again, the answer for this question is alcoholic hepatitis. But however, the question might have been a little different. If you feel the question is little different, just let me know. Lilly model is also based on how much the bilirubin reduces by day 7. And based on that, they can tell you whether the patient is going to respond to steroids or not. This will help us decide to stop steroids at day 7. Okay. The next question is, motilin receptor agonist used in GI disorders is erythromycin. We all know that motilin receptor agonist is erythromycin. If you have the question little different or all the options for this question, do let me know. But however, it's a simple, straightforward question. Erythromycin is the answer. Next, yes, this question again, QRP based question. We had clearly discussed this. A patient presenting with abdomen pain, high SAG, high protein ascites. High SAG, high protein means there are only suprahepatic causes. So suprahepatic causes are Budd-Chiari syndrome and right heart failure. So in the option, if right heart failure was given, then it is a very close option, but Budd-Chiari syndrome would be the definitive answer for this. And they had also told that few of the students have told that there was one more question which said right upper quadrant pain, normal LFT, ascites, but polycythemia. What will you go for? You go for Budd-Chiari syndrome, probably because the Budd-Chiari syndrome is secondary to the polycythemia which is there, which could be secondary to myeloproliferative disorder. Okay, so despite the patient has, portal hypertension with a splenomegaly where you expect a low platelet count, if you have a higher platelet count, then you know that you are dealing with myeloproliferative disorder as the diagnosis which is presented as Budd-Chiari syndrome. Okay, so that would be the probable answer. If you feel the question is slightly different, do let me know in the chat box. Next question is, which of the following is not associated with HCV? B cell Hodgkin's lymphoma. Obviously, B cell or Hodgkin's is not associated. The one which is classically associated with this primarily is HCC. Secondarily is a lot of things, but most important is B cell non-Hodgkin's lymphoma. Okay, so that's what you guys should know. If you have little doubt or if you feel the options a little different, please do let me know. Now, Faget sign is seen in option is enteric fever, but I'm not sure what were the other options. Please put up in the chat box if you feel so. This is a clear-cut explanation. Faget sign is also called a sigmothermic dissociation, which means that the patient has fever but has bradycardia, that is high volume pulse. Okay, so usually fever is associated with tachycardia, that is a classical sign. But there are a few conditions where there may be associated bradycardia, which can be in typhoid fever. It can also be the yellow fever. It can be happen in brain abscess, tularemia, brucellosis, choleratic fever, and some pneumonias, especially when the organism is intracellular. If the organism has intracellular life cycle, chances of having a bradycardia is seen. Even fever, especially beta blockers, we see as liver doctors, we see patients on beta blockers having fever. You see here and there patients have bradycardia. There is no fever but no tachycardia. Even in drug-induced, you can get this kind of pattern, especially it's called a beta Faget sign. Okay. Now, true about TPN. True about TPN among the option given is lipid started after 24 hours? No, TPN has all of it mixed. We mix it and then give. So lipid started after 24 hours doesn't make much sense. LFT and triglycerides to monitor is important because you have to look for new onset NASH or TPN induced liver disease, which can happen in few patients. Capillary glucose maintained between 1 to 180 is wrong. It has to be maintained between 100 to 140, but however, up to 180 is fine in non-diabetics, but in diabetics it should be less than 140. Okay, dextrose should be given 250 to 200. No, it should be less than 200 milligrams. Okay, so the best answer for this would be LFTs and triglycerides being monitored. If, however, you feel the question is slightly different, please do let me know, guys. Next question, again, a straightforward question: recurrent pain, diarrhea, weight loss. You take a biopsy, it shows non-caseating granuloma. Non-caseating granuloma with skip lesion. Answer is Crohn's disease without any doubt. Okay. Ileal resection done, which vitamin is deficient? It is vitamin B12 again, and straightforward question. No need to even discuss. I think it's an easy question. Larva currents. Now, larva currents is because of Strongyloides stercoralis, and that would be the right answer. But however, if they have mentioned in the question creeping eruptions, then the answer will be cutaneous larva migrans secondary to cat, hunt, dog, hookworm. So be clear on the question. If the question at larva currents, Strongyloides stercoralis is the right answer for this question. Feel free to tell the right options if there are any other options in the question. Okay. Next question is, delirium treatment of choice is a benzodiazepine, short-acting benzodiazepine. Okay. If you guys feel there were some other options, do let me know, but the best answer will be diazepam. Okay. Next, cell responsible for fibrosis in a case of cirrhosis of liver is again it's stellate cells. If they mentioned ito cells or Kupffer cells or something else, then that is not the answer. It is stellate cells. Okay, the answer is stellate cells. That's about it. Totally 25 questions I could gather from what I could discuss with you of our students. So guys, just let me know if you feel any discussion that we have to discuss based on the questions or options. If you feel it was different, then we have a separate group for NEET SS discussion. So feel free to contact me. I'll add you into the group. 740-664-8141 is my number. So if you ask for an invitation, I'll put you into a WhatsApp group, which will take care of few of the discussions, or also there's a big Telegram group where we try to discuss common questions, especially 1 or 2 months before the main exams. So you guys can feel free to contact me on that. Guys, if you feel that there has to be some changes, or the questions which I discussed and what I could jot down is a little different, please feel free to let me know what the questions were. So far, 25 questions in gastroenterology and liver diseases is a phenomenal number considering the overall progress of the questions. 25 questions out of 150 is a very good number. So hope our QRP sessions really helped you. I'll wait for again 20 more seconds to just see if there are any new questions in the chat box. Okay. So one of the students has told there was no mention of vaccines. Dr. Deepak, if they have not mentioned about vaccine, then it depends upon what the options exactly were. If it was NGRX-B, I would go for 0, 1, 2, and 12, or 1 year. Okay. Then abdomen pain is present for patient in question 2. That's long ago. That is okay. Extrahepatic manifestation of hepatitis C. Okay, Dr. Kunal Gupta, that's great. Then it's straightforward. It's more specific that cryoglobulinemia was there. Okay. Let's see. There's a small lag between what I'm telling and seeing. So, guys, any other questions? 25 questions. Options have been discussed. Let's see. I hope most of the discussion is over. And so far, which book to read? TPN to cover all questions. What is it? Okay, fine. One of your Dr. Neelima asked which book to read for TPN. For TPN, I think Harrison doesn't have much details on it. It's specifically asked from Schlesinger, and Schlesinger also doesn't have answers for all the exact details. I think you can go to Schlesinger just for TPN. How to administer, what to monitor, especially the electrolytes has been mentioned well in that. However, yeah, see, when they ask you questions, it doesn't mean that everything will be from Harrison. This is a classic example that sometimes specialist-based topics may be asked, and TPN in that view becomes important. Even for INISS, TPN itself is an important question. We will discuss more, a little more on TPN when it comes to the discussion. Okay. Yeah, exactly, Dr. Neelima. Like you have said, Harrison is not covering all the points. But see, when you are preparing for an exam like NEET SS of this magnitude, where anything and everything should be known, but you cannot know everything in a single subject. Okay, so it's sad that they have asked questions out of the main book, but if you see TPN per se, it may not just be a gastro question. It has a lot of implications for oncological patients, for any patient where enteral nutrition is not possible. There are some things which, as physicians, also we should know about TPN and how to monitor after starting TPN. So maybe because of its implication, that particular question has been asked. Okay, so I would say that a mix of everything is important. But if they ask you 25 questions from gastro and liver, I assume that there will be 4 to 5 questions which everybody will feel difficult. Even us practicing may find 2 options really close, and we might also mark it wrong. So that's expected and that can happen, but it's okay. If you ask me best book to read, first would be Harrison. Go through them well, and then if you have time, go through Schlesinger tables. But if you're INISS aspirant, I would say that go through the main books, and then will be classic classes having recent guidelines and what are the recent changes. That would be the one which would be helping you the most. Okay. Fine, then guys, thank you for giving us this opportunity to discuss these questions in such short notice. We had real great fun discussing these with you. My phone number has been shared with you guys. Please request me to just add on to the group. We will definitely add you on to the group, and best of luck for the results. Thank you.